mechanics of breathing in health and disease. So we're going to talk about some normal physiology, and then we're going to roll into that some of the physiology of the mechanics of breathing as we may see on sick patients on ventilators. So our objectives are to describe the pressure-volume relationships of the lungs, the chest wall, and the respiratory system, to discuss the effects of the pleural pressure gradient, to compare laminar and turbulent flow, to describe the effects of the equal pressure point. I think that's what you were just alluding to, Patty. Measure resistance and compliance during mechanical ventilation, describe time constant work of breathing and the equation of motion, and then to apply assessments of respiratory mechanics to mechanically ventilated patients. So to begin, let's talk about the pressure-volume relationship of the lungs and respiratory system compliance. So what we're looking at here is volume on the y-axis as a function of pressure on the x-axis. And let's imagine for a minute that we take the lungs out of the chest wall. So imagine we took the lungs out of the chest wall, put them on the table, increased the volume within those lungs, and then measured the relaxation pressure. So that's what happens along this curve that is marked lung. As you can see, at any volume, the pressure inside of the lung will be positive. So, in other words, at any distending volume, the tendency of the lungs is to collapse inward, to produce a positive pressure. So the effect of the lungs is always to collapse inward. Now let's imagine that we take the chest wall and we do the same experiment. So we take the lungs out of the chest wall and we measure the pressure inside the chest wall at a number of different distending volumes. So you can see that for the chest wall, the tendency is for the chest wall to expand outward except at very high lung volumes. So that the chest wall by itself generates a negative pressure. It's trying to go out. And then if we put them both together, which is the normal circumstance, we end up with this curve, this kind of solid line, sigmoidal, S-shaped curve, which is the lungs and the chest wall together, which is the sum of this line and this line. So then the isolated chest wall expands outward except for at very high lung volumes. So that results in negative pressures from the chest wall. The isolated lung collapses inward, produces positive pressure at all lung volumes. At functional residual capacity, the alveolar pressure is 0, this point right here, and the pleural pressure is negative because the chest wall is trying to go out and the lungs trying to go in, so they're working against one another. So the intrapleural pressure is negative. And one of the implications of this is that physiologic PEEP is 0. So there's no such thing as physiologic PEEP. So there are lots of reasons why we set PEEP on the ventilator. Lots of good reasons. One of those reasons should not be because it's physiologic. Because physiologic PEEP, as shown here, is 0. So for you and me, at the end of exhalation, our alveolar pressure is 0. The normal compliance, so the slope of this line, change in volume over change in pressure, the slope of these lines is compliance. The slope of the lung compliance curve is 0.2 or 0.2 liters or 200 milliliters per centimeter of water. The slope of the chest wall line, as you can see, is very similar, about 0.2 liters or 200 milliliters per centimeter of water. Notice that if we put the two lines together, the slope is less. So this is a steep slope, this is a lesser slope, and the compliance of the respiratory system compliance is about 0.1 liters per centimeter of water or 100 milliliters per centimeter of water. So what's the normal compliance of the respiratory system? 100 milliliters per centimeter of water. Come back to that when we talk about compliance on the ventilator. And mathematically, you can work through the math, the elastance of the lung plus the chest wall is the respiratory system elastance. And if you go through the math also shows that the compliance of the respiratory system is about 100 milliliters per centimeter of water. Now, compliance, the shape of the curve. So the shape of this curve changes with disease. So, for example, if this is the normal volume-pressure relationship, with emphysema, the curve shifts to the left. And the reason why the curve shifts to the left is because with emphysema, there is destruction of lung parenchyma, there's destruction of alveoli, so there's loss of the normal inward elasticity of the lungs. So in patients with COPD and emphysema, the lung compliance is actually increased. The slope of this line is increased. And we see that clinically, right? So how do we see that clinically? You look at a COPD patient, and how do you see that clinically? The barrel chest. So there's a loss of the inward elastic recoil of the lungs. On the other hand, with pulmonary fibrosis and ARDS and obesity and other restrictive lung diseases, notice that the curve is shifted to the right. So there is a decrease in compliance, a decrease in the slope of this line, a decrease in the volume change for pressure change in patients with restrictive lung disease. And there's also a decrease in lung volume, as this illustrates. So with restrictive lung disease, a decrease in lung volume. And with emphysema, as you know, patients are hyperinflated, they have an increase in lung volume. Barrel chest. So, then how does some of this compare to what we see clinically in patients with ARDS? So if this is functional residual capacity, normally the volume-pressure relationship is relatively linear. Notice that with ARDS, the volume-pressure relationship shifts to the right, and there's a lower volume. And from functional residual capacity, notice that the curve now has this sigmoidal S-shaped relationship. Normally, for you and me, the pressure volume curve of the respiratory system is determined by the elastance of the system. The elastance or the compliance of the lungs and the chest wall. With ARDS, however, the volume pressure relationship is determined not only by elastance but also by lung recruitment and de-recruitment. So one of the characteristics of ARDS is that there is alveolar collapse. On this curve with ARDS, there's a lower inflection point where the curvature changes here, an upper inflection point where the curvature changes here. So it is thought that the lower inflection point is the point where there is significant alveolar recruitment, but there's actually recruitment that occurs the whole way along the pressure volume curve with ARDS. And it is thought that the upper inflection point was the end of recruitment and the start of overdistension in patients with ARDS. So it would make sense then that we would want to set the ventilator for this part of the volume pressure curve. So above the point of significant alveolar recruitment, by how we set P to maintain alveolar recruitment, and below the upper inflection point, which represents the point of overdistension. So you would think then that, well, this is what we should do this on our mechanically ventilated patients and set the ventilator accordingly, but it's not as easy as it seems. So to determine these curves, and I'll show you how we do that on the next slide, to determine these curves requires sedation and often paralysis. So is it worth paralyzing the patient to get this information? It's really difficult to identify these inflection points. About 20 years ago, some of us, myself included, worked out the mathematical relationship of this where we could figure out precisely this point and this point, but that's difficult to do at the bedside. There are lung versus chest wall effects on the pressure volume curve. So some have argued to do this, you really need to put in an esophageal balloon and get pleural pressure. And this is the inflation curve, and maybe the deflation curve. How the lung deflates is more important to determine the point of collapse. So a couple of years ago, Purvis will remember, and maybe Vinny, we thought that this was really cool, and we would run around the ICUs, and Patty, you probably remember, and generate these kinds of curves. And it fell out of favor because it's a difficult thing to do, and whether or not it improves outcomes over a lung protective strategy with 6 mLs per kilogram and appropriate PEEP is really not clear. So then how can we do this? Well, the way that we used to do it. And Purvis is laughing because he can remember. And maybe you remember, Patty. So we had this 3-liter syringe, like is used in the pulmonary function lab to calibrate the spirometer.
Yeah.
And we would put a filter on there, and we put a T-piece and a pressure manometer. And then we would push in 100 milliliters and write down the pressure. And then another 100 milliliters and write down the pressure. And go up to pressures of 35 or 40 centimeters of water. And then we would, on graph paper, we would plot out these curves and we would try to eyeball where's the lower and the upper inflection point. Really not very practical. Fun thing to do as part of research projects, but not a very practical thing to do as far as everyday ventilator management. Now you may be thinking, well, why don't we just take it right off of the ventilator? Because all of the ventilators have a PV curve function. So you can switch the ventilator to the PV curve function. You look at it right on the screen. Well, the problem with that is that it is very dependent upon how the ventilator is set. So these are some curves that I generated off of a lung model probably 20 years ago now, on the table right in front of where Patty's sitting, and illustrated very nicely that on a lung model, this is what the PV curve looks like on the ventilator with constant flow volume control ventilation. And if you switch the ventilator to pressure control, and the same tidal volume, the same peak, and now on pressure control, it looks like there's a lower inflection point when there is really not, because this is a function not of the elastance of the system, but how the ventilator delivers flow during pressure control. And I used to remember, so I'm not going to mention any names, and these are people, physicians who aren't here anymore anyway, but when we were enthusiastic about PV curves a couple of years ago, I would go into the MICU and some well-meaning intensivist had the therapist change the ventilator to the pressure volume curve so that on rounds they could see where to set the peak. Problem was the patient's on pressure support. That invalidates the whole thing. Now that said, there is one ventilator on the market, and the only one I believe is the Hamilton, and I don't know if you know of any others that do a true pressure volume curve. So what the Hamilton ventilator will do is a very slow inflation of the lungs, like at a flow of 5 liters per minute, I believe it is. Very slow inflation. It's almost like the syringe, pushing it in and pushing in more liters. And with the PV curve function on the Hamilton ventilator, you can slowly inflate, you can hold the pressure, measure the amount of recruitment, slowly deflate. And I have to say that I think the Hamilton ventilator does it correctly. I think this is a true PV curve, very similar to this one. But we're still left with, number one, does it make any difference in patient outcomes if you have this information and set the ventilator accordingly? And number two, you don't have Hamilton ventilators, you can't do this, because I don't think there are any other ventilators that allow this. Now when talking about the pressure-volume relationship of the lungs, we also should discuss the pleural pressure gradient. And the pleural pressure gradient states that the pressure at the top of the lungs, in other words, in the upright lung, the pressure at the top of the lungs at the apex is more negative than the pressure at the bottom of the lungs. So the pleural pressure is negative throughout, normal for you and me. but it's more negative at the top than it is at the bottom. So that has some important and interesting physiologic implications. So alveoli near the top of the lung exposed to a more negative pleural pressure are at a less compliant part of the volume pressure curve. Whereas alveoli at the bottom of the lung exposed to a less negative pleural pressure on a more compliant part of the pressure volume curve. So the slope of this line is greater than the slope of this line. So that has a couple of physiologic implications. First of all, alveoli at the top of the lung are bigger than alveoli at the bottom of the lung. And the reason for that is they're exposed to a greater distending pressure, more negative pleural pressure. Secondly, most of the ventilation goes to the bottom of the lungs. And the reason why most of the ventilation goes to the bottom of the lungs is because those alveoli are on a more compliant part of the volume pressure curve. So as you and I are normally breathing right now, the distribution of ventilation is more to the bottom of the lungs than to the top of our lungs, and that is the result of the pleural pressure gradient. Now, the pleural pressure gradient also becomes important when there's a decrease in lung volume. So let's now imagine that the lung volume decreases for whatever reason. ARDS, congestive heart failure. Lung volume decreases. So if the lung volume decreases dependently, so a patient, post-op patient who develops post-operative atelectasis tend to hear the crackles more at the bases, because that's where the atelectasis occurs first. And now with a decrease in lung volume, the ventilation, the alveoli at the top of the lungs are the alveoli that tend to be better ventilated. But the problem is most of the blood flows to the bottom of the lungs. So now we have more blood flow down here to alveoli that are collapsed, more blood flow, less blood flow up here where the alveoli are being ventilated better, and so our patient is hypoxic. And then we do things to try to increase the lung volume, such as with PEEP, because if we can use PEEP and reestablish the lung volume, then we reestablish this relationship. This also has implications when we think about why we will place a patient prone who has severe ARDS. In a patient with ARDS, lying supine, the pleural pressure is more negative in the top of the lungs, which is the ventral lung, than it is in the dorsal lung, which is at the base of the lung. And notice that there is a very high pleural pressure gradient, from -10 in this example at the top of the lung to +15 at the bottom of the lung, and the +15 results in collapse and dependent alveoli. So we see that on a CT scan in patients with ARDS, and that contributes to the patient's hypoxemia. Now what happens, and this has been shown to occur at least in animal models, is if we take this lung with ARDS and turn the patient from supine to prone, the pleural pressure gradient becomes smaller from the top of the lung to the bottom of the lung. So here we have a pleural pressure gradient of 25 centimeters of water, right? -10 to +15. Here we only have a pleural pressure gradient of -8. So the pleural pressure gradient is less. And notice that now the dorsal lungs, which are the ones now on the top, if you're prone, have a negative pressure of -10 in this case. But the ventral alveoli, which are the ones on the bottom when we're prone, have a less negative pressure, but it's still negative. So that then results in recruitment of these alveoli. So there's less atelectasis, and we see that clinically as the patient's oxygen saturation of PO2 and shunt. PO2 go up and shunt goes down. So the pleural pressure gradient then is used to explain why patients with ARDS have better gas exchange if we turn them into a prone position. Now we think about the pressure-volume relationship of the lungs. It also helps us to understand why the compliance is decreased with a loss of lung volume. So the question then that comes up sometimes is, well, why does the compliance decrease when lung volume decreases if we haven't changed the elasticity of the lungs and we haven't changed surface tension and so forth in the lungs? Why is it that simply a reduction in lung volume, such as with consolidation or atelectasis, should result in compliance decreasing? Well, here I think is the explanation for that. So let's imagine that we push a volume of gas into two alveoli. Half of the volume goes into the alveolus in the left, half of the volume goes into the alveolus in the right. Each of those alveoli may have a volume change from here to here. And the slope of this red arrow is going to be the compliance of these alveoli in the system. But now let's imagine that this individual develops a pneumonia with consolidation. So the part of the lung that is consolidated is not participating in ventilation, but the rest of the lung has normal elasticity, has normal surface tension. The rest of the lung parenchyma is perfectly normal. It's just that maybe there's one lobe that's consolidated. Well, if we illustrate this with two alveoli, now if we push in the same tidal volume on the right as we did on the left, all of that tidal volume now goes to one alveolus. So now the pressure change in volume change in this alveolus doesn't go from here to here, it goes from here to here. Because all of the breath goes into, in this example, this lung unit. And this lung unit essentially overextends. So now if we take the slope of the purple line from here to here, the slope is decreased. The volume change per unit of pressure change is decreased. Compliance is a change in volume over the change in pressure. So then the reason why we see a decrease in compliance with consolidation and atelectasis and pulmonary edema and so forth is because we're trying to push the same volume into a smaller space. And in fact, so what would you recommend that we do so that we avoid this situation from occurring? Really what's done pretty commonly clinically. So what do you do? So what, if you wanted to avoid this from happening, what would you do?
Decrease the volume?
Decrease the tidal volume. So decreasing the tidal volume then avoids this problem. I have to tell you, it took me a lot of years to figure this out. Over the years, I had a lot of people who would ask me, why should the compliance go down if you get a pneumonia if the rest of the lung is normal? And I think this is the explanation for that. Okay, so then we said, so here's our volume-pressure relationship again. We said that compliance is a change in volume over the change in pressure. So we may want to know what the compliance is, what the slope of this line is clinically. So it might be helpful clinically to know, is the compliance increase, decrease, normally? Or in other words, what is the slope of this line? So one way that we might do that is we could determine for an individual patient the pressure-volume relationship, do a PV curve. And we could determine the slope of the line at this point, or at this point, or at this point. So if this is the FRC, we could determine the slope here. If this is the FRC, we could determine the slope here. That's hard to do. We already said that it's very difficult clinically to determine the pressure-volume curve for a patient. We have to take a syringe to the bedside and do that exercise. The other thing is that to determine the slope at any point along here, we have to do calculus. We have to do derivatives. And for me, that's kind of beyond what I can do at the bedside. Maybe not for you. So then what do? Well, we do cord compliance. So what we do is we determine compliance from some starting point, the FRC, up to a tidal volume change above that FRC. So maybe this is our peak, and then we push in this tidal volume, and this is our plateau pressure. And that's how we more commonly will measure compliance at the bedside. So what we do at the bedside when we measure compliance on a ventilated patient is we measure cord compliance. It's not at a specific point on the curve. So this is what we do. We all know how to do this. So compliance is volume change over pressure change. That's tidal volume divided by plateau pressure minus peak. The tidal volume is the tidal volume that actually goes down the endotracheal tube, so it needs to be corrected for gas compression. Some of you will remember when we had to do that at the bedside. Fortunately now, the ventilator does that automatically based upon the pre-use check that we do. So the tidal volume that the ventilator reads out is the tidal volume after correction for gas compression. And the PEEP in this relationship needs to be the total PEEP, including any auto PEEP that the patient has. So what does that mean? Well, what that means is that when you press the breath hold button on the ventilator, and the ventilator does a plateau pressure and it calculates out the compliance for you, that compliance calculation is always wrong if the patient has auto PEEP. Because the ventilator bases this off of the PEEP that is dialed in on the ventilator, not the amount of auto PEEP. So if the patient has any auto PEEP, you need to calculate the compliance yourself the old-fashioned way with this relationship. The compliance can be decreased with a lot of things. Compliance is not a very specific measure. It can be affected by things that are happening in the lungs. So lung disease can decrease compliance. Pleural disease can decrease compliance. And chest wall disease can decrease compliance. And really, if you wanted to sort this out, you'd have to put in an esophageal balloon and measure the pleural pressure and calculate the chest wall compliance and so forth. Something that can be done, not done a whole lot as part of everyday clinical practice. So normal compliance we had already established is 100 milliliters per centimeter of water. A lot of critical care textbooks and some respiratory textbooks will tell you that a normal compliance is 50 milliliters per centimeter of water. Because usually in a critically ill patient, a compliance of more than 50 is pretty good for somebody on the ventilator. But it's not normal. Maybe acceptable, but normal is 100. So, I missed a point here. So the denominator of the compliance equation is driving pressure. So the difference between plateau pressure and PEEP is what is called driving pressure, and this has received a lot of attention in the literature over the last couple of years and has received a lot of attention clinically as well. And the reason for that is based upon this paper, where it was shown that in patients with ARDS, on the y-axis, we're looking at the risk of death, the risk of dying in the hospital. And on the x-axis, we're looking at driving pressure, the difference between the plateau pressure and the PEEP. And again, this is plateau pressure minus total PEEP, including any auto PEEP the patient may have. And what you can see is that when the driving pressure is less than 15 centimeters of water, the risk of death decreases to less than 1. So there's a lower mortality with a lower driving pressure. So this then would suggest that one of our targets during mechanical ventilation is to maintain the driving pressure less than 15 centimeters of water. A driving pressure greater than 15 increases, and it may significantly increase the risk of death. So then one of our targets, again, should be plateau pressure, the denominator of the compliance curve, to less than 15 centimeters of water. And in fact, how we set the tidal volume and the plateau pressure are going to be what will determine the driving pressure. So if we turn up the PEEP and the driving pressure goes from 12 to 20, not a good thing. But if we turn up the PEEP and we get alveolar recruitment and the driving pressure goes from 18 to 12, that's a good thing. Or if the tidal volume is 7 mLs per kilogram and the driving pressure is 18, then we decrease the tidal volume to 5 mLs per kilogram and the plateau pressure is 13. That's a good thing. And I think one of the nice things about plateau pressure is pretty easy to calculate, right? You don't need your calculator to determine the driving pressure. You may need your calculator to calculate the compliance, I would usually, but not for driving pressure. Okay, so now let's talk about airways resistance. I think we're doing okay. I want to spend half of the time on compliance and half of the time on resistance, so we'll see how this works out. So airways resistance. So airways resistance has to do with flow through airways. And the flow through airways can either be laminar flow, very smooth flow, as is illustrated here, or turbulent flow, which is very haphazard, as is shown here. And as this figure might illustrate, laminar flow is efficient, turbulent flow is inefficient. We're going to expand more on that in a minute. So ideally we would want to promote laminar flow rather than turbulent flow. So what will determine whether flow is laminar or turbulent? Well, this is determined by something called the Reynolds number, which is the ratio of the inertial to viscous forces. The viscous forces are determined by viscosity. So this mu, this Greek letter mu, is viscosity. Inertial forces are determined by the velocity of the flow. So not how fast the flow is, not the amount of flow. So it's not flow rate, it's velocity, which is the speed of the flow. The radius of the airway and the density of the gas. So rho here is density. If we lower the Reynolds number, we get laminar flow. If we increase the Reynolds number, we get turbulent flow. It turns out that based upon the Reynolds number, in the small airways of our lungs, the flow is laminar, and in large airways, it is turbulent, and that is because of the effective radius. So small airways have a much lower radius, so that will lower the Reynolds number, gas flow will be laminar. Large airways will have a higher radius, that will increase the Reynolds number, gas flow will tend to be more turbulent. So, think about the gas through your central airways and upper airway, turbulent. Gas flow through the small airways of the lungs is laminar, it's moving along much more efficiently. Now, more math. So no calculus, but algebra. So more math. So this relationship describes the amount of pressure to generate turbulent flow versus laminar flow. And I think you can appreciate several things. First of all, it takes a lot more pressure for turbulent flow. So flow is squared here rather than flow to the first power. Radius is to the fifth power in the denominator rather than radius to the fourth power. So laminar flow takes a lot more pressure. So it's less efficient. It's harder to generate turbulent flow than it is for laminar flow. But also notice that the equation for turbulent flow includes density. The equation for laminar flow includes viscosity but not density. So gas flow through small airways where there's laminar flow is density independent. So if you change the density of the gas that you're breathing, it might affect the amount of pressure to get flow through large airways but not small airways. So what might be the clinical implications of that? How do we change the density of the gas? Well, you can look at your handout and you probably already know that's with heliox. So we decrease the gas density, which is what we do with heliox. And by the way, the viscosity of heliox is not much different for air and for heliox. But if we decrease gas density with heliox, we would expect that that would be beneficial in large airways where there's turbulent flow, but not so much for small airways where there's laminar flow. So what type of patient is going to benefit from Heliox? Well, this physics would say the patient who's likely to benefit from Heliox is the patient who has a large airway obstruction, like an upper airway obstruction, like stridor. Whereas you would not expect that Heliox would have much benefit in patients with COPD. And some patients with asthma benefit from Heliox and some do not. And I think it is determined by where the site of the obstruction is, primarily in that patient with Heliox. So is it primarily large airways or small airways affected by the disease? So how often have you run out in a patient to see a patient with COPD exacerbation and drug along a Heliox tank? I hope not very often, because this would suggest that it's not going to be very helpful. And you'd be better off dragging along a BiPAP machine than dragging along a Heliox tank. Now illustrated here are the volume and pressure and flow changes in the lungs as we are breathing normally. So as you can see, normal inspired tidal volume about 400 milliliters. Turns out that's about 6 mLs per kilogram. So we talk about using low tidal volume ventilation for ARDS. We're actually using normal tidal volume ventilation with 6 mLs per kilo. Notice that the interpleural pressure drops by about 3 centimeters of water to pull 400 milliliters of gas into the lungs. The flow in and out of the lungs normally is sinusoidal, so this is a sine wave. And the inspiratory and expiratory flows, peak flows, are about a half liter per second or 30 liters per minute. Hence the recommendation that with a high flow oxygen delivery system, the flow should be at least 30 liters per minute. This is where that comes from. And the alveolar pressure fluctuates about a centimeter of water, negative during inspiration and positive during exhalation. So this is what happens as you and I are breathing normally. Now back to airways resistance. So where is most of the resistance to flow as we breathe in? So we take a breath in, that requires pressure. Is that pressure primarily due to resistance in the large airways or the small airways? Well, this slide answers that question. So here's airways resistance and here's airway generation. So this is trachea, this is terminal bronchial. Most of the resistance, as you will see, is in the central airways. Very little resistance, much less resistance in the small terminal bronchioles. So how do we explain that? How do we explain that the resistance through the trachea, like this, is greater than the resistance through the terminal bronchioles, each of which is like this? And the answer is, how many trachea do you have? One. All of the flow needs to go through the trachea. How many terminal bronchioles do you have? Millions. So what is important is the total cross-sectional area. So you take all of those small terminal airways that have the same cross-sectional area, you put them all together, you end up with an area like this, not an area like this. Because the gas is being divided among all of those bronchioles in parallel. It doesn't go through each one individually. Airways resistance is also affected by lung volume. So you can see with a higher lung volume, airways resistance goes down. Why is that? Well, that is because of the tethering effect of the alveoli. So the alveoli between the lung surface and the airway is tending to pull in on the chest wall and pull out on the airways. So the tethering effect of the airways is to keep, the tethering effect of alveoli is to keep airways open. So when you increase the volume of the chest, that pulls out more on airways. So the resistance goes down, and so the radius goes up and the resistance goes down. Whereas with a lower lung volume, there's a loss of that tethering effect. The radius of the airway goes down and the resistance goes up. Now, in patients with emphysema, COPD, there is destruction of alveoli. So with diseases like emphysema and COPD, there's a loss of that tethering effect because of destruction of alveoli, and for that reason the airways become more floppy. They are more likely to collapse, and the airways resistance and worker breathing then is increased in patients with COPD where there's alveolar destruction. Now there is an interesting relationship between expiratory flow and effort. So we're going to get into equal pressure points in just a minute. So it sounds like Corey told you all about that earlier. So let's see if I say the same thing. So let's say we take in a relatively low lung volume. So we go maybe just twice the tidal volume. And then we blow out as hard as we can. What we find is that the flow increases up to a point at which, doesn't matter how hard you push, no more flow comes out. And now we increase lung volume a little bit more. So 4 times the tidal volume we breathe in. Then we blow out hard. Flow goes up. The flow goes higher with a higher increase, with an increase in lung volume, but you still reach this point where the flow plateaus. And you push harder and harder and harder, and here it doesn't matter how hard you push, no more flow comes out of the lungs. And at a very high lung volume, you can't really reach the plateau because you can't push that hard at a high lung volume. So why is that? So why is there this expiratory flow limitation? Why is it that the harder you push, no more flow comes out of the lungs? Well, that has to do with something called the equal pressure. So what I've illustrated here on this cartoon, I hope it makes sense because this took me about an hour to draw this. So here is the chest wall. So imagine this is the chest wall, here is the lung parenchyma, here are the airways. The space between the chest wall and the lung is the pleural space. So when we push out hard, we're driving up the intrapleural pressure. The pressure in the alveolus is the pressure generated by pushing out, as well as the elastic recoil pressure of the alveolus, the tendency of the alveolus to collapse inward, as we talked about. So in this example, let's say you generate a pleural pressure of 30 centimeters of water. The elastic recoil pressure is 5, so there's 35 centimeters of water pushing gas out of the lungs. And out here is atmosphere 0. This is the upper airway here. So this is the pharynx and the upper airway. Now the pressure, when we're pushing out, the pressure that is applied to the alveolus is also applied to the airway. So the airways see the same pressure as the alveolus does. So that pressure is pushing not only on the alveolus, but also on the outside of the airway. As gas flows out of the airway, due to airways resistance, its pressure decreases. So let's say we go 35, 34, 33, 32, 31, 30. At this point, the pressure outside the alveolus is equal to the pressure inside the alveolus. So now if you push harder, you're not going to get any more flow. So you push harder, that increases the driving pressure up here, but by the same amount, it decreases the collapsing effect on the alveolus. So because the airway is collapsible, so this, by the way, is the equal pressure point, and the airways act like what is called a Starling resistor. Because the airway is collapsible, radius is determined by the pressure gradient across the airway. The equal pressure point is when the pleural pressure equals the airway pressure. Flow then is determined primarily by the elastic recoil pressure, not how hard you push. So here we push in with plus 60 instead of plus 30, and the result is the equal pressure point occurs at exactly the same place, because the pressure is applied not only to the alveolus but to the airway. Normally, the equal pressure point is in a large airway, so like the trachea, main stem bronchi, and they are supported by cartilage, so they do not completely collapse when you reach the equal pressure point. However, what's going to happen if the cartilage is destroyed? Tracheal malacia. Then you're going to have potentially this airway collapsing unless you provide some kind of positive pressure inside the airway. So with tracheal malacia, PEEP will be affected, for example, because the PEEP pressure will tend to prevent this collapsing effect. Is this your patient upstairs?
Yeah, but I think he was saying that it was flow limited, so
Yep.
PEEP would not help. Even though we saw floppy airways under the scope on exhalation.
Well, an interesting experiment to do would have been to keep the scope in the airway and add PEEP, because PEEP and CPAP can be actually clinically very effective with tracheal malacia.
Right.
And I mean, in babies, I think this is done pretty
exactly
commonly.
And
I mean, I haven't taken care of babies other than my grandkids in a long time. But back in the day, we would send kids home with tracheal malacia on CPAP for this.
Yeah, so I don't know if it was clear that it was actually tracheal malacia. He thought it was at the end of exhalation. What we saw under the scope, he thought she was pulling in on a mucous membrane or something. She was saying, yeah. Well, anyways, different patient.
Yeah.
But that's what I suggested, more PEEP. But
Yeah. So now this will create, this whole concept will create issues if we have an increase in airways resistance. So if we put bronchoconstriction or mucus, say right here, now the pressure is going to drop off more quickly. So that'll be a problem, because now maybe the equal pressure point will not be in a central airway, be more peripheral where there's not as much cartilage. Or imagine there's less elastic recoil pressure, such as with COPD. So that is illustrated on this slide. So actually, once I got this slide down, this one only took about 5 minutes. So now let's imagine that we put an obstruction in the airway. So that could be bronchoconstriction with asthma, that could be mucus with cystic fibrosis. So due to this obstruction, there will be a bigger pressure drop across the airway due to the obstruction. So the result then is that the equal pressure point will occur further upstream, closer to the alveolus. And it might occur in airways that do not have the cartilaginous support of central airway. So then what we get is dependent small airway closure. So all the airways in the lungs don't just flap down closed, because we have the pleural pressure gradient again. So it's going to tend to occur more in the dependent parts of the lungs. Or if there is a loss of elastic recoil pressure, say from 5 to 3 as with emphysema, we can get the same effect. And this produces the characteristic flow volume curves that we see with asthma and with COPD. And with severe COPD, we commonly see that the flow reaches a peak and then it drops off very quickly. And the reason why it drops off very quickly is the patient is pushing, and the harder they push, the more upstream is the equal pressure point. The more upstream is the equal pressure point, the more small airways collapse and flow is decreased. Okay. By the way, we can evaluate this clinically. It just now occurred to me, I should have put in a slide or two about how we can evaluate this clinically at the bedside. And what we can do is, in a patient with COPD, if there's question about the patient being flow limited, which is what this is, flow limitation, we can evaluate that by looking at the flow waveform on the ventilator graphics and pushing on the patient's belly. And if you push on the patient's belly and you drive up the intrapleural pressure and there's no more flow coming out of the lungs, so you get a plateau in the flow waveform on the ventilator, that means the patient's flow limited. So we used to do that from time to time up in the MICU when we had patients with severe COPD, and actually, and that's how we would determine that the patient's flow limited, and add PEEP to counterbalance all the PEEPs that the patient could trigger. So it just now occurred to me I should have put in some slides about that. Next time. So we can measure inspiratory airways resistance in patients on the ventilator, which is PIP minus plateau divided by flow. Typically, this is measured at a flow of 30 liters per minute or 60 liters per minute because that makes the math easy. The units are centimeters of water per liter per second. And if we set the ventilator on 60 liters per minute, PIP minus plateau is resistance. If we set the ventilator at 30 liters per minute, PIP minus plateau times 2 is airways resistance. We have to do this during constant flow volume controlled ventilation. So we can't do this during pressure control. Normal airways resistance in a mechanically ventilated patient, typically if the difference between PIP and plateau is greater than about 10, that is abnormal. Should also point out this is inspiratory resistance. Expiratory resistance will be greater, and expiratory resistance is actually a bit more difficult to calculate. So airways resistance might be increased with secretions, bronchospasm, small endotracheal tube, or low lung volume. So years ago I heard a pulmonologist refer to an increase in airways resistance with ARDS is due to a low lung volume, which is correct. And he called it obstruction, so I thought that was kind of cool. So it's obstruction. It's apparent obstruction as a result of restrictive lung disease. Kind of a cool concept. So with the time that we have left, we're going to talk for a minute about some composite measures that we can think about. One being time constant. By definition, time constant, Greek letter tau, is equal to resistance times compliance. Normal resistance is about 1. Normal compliance is about 0.1. So normal time constant is about 1/10 of a second. Work of breathing is the pressure times volume integral. So this takes calculus actually to calculate this. Normal is about 0.3 to 0.7 joules per liter. If you have a tidal volume of 400 milliliters and an inspiratory pleural pressure change of 3 centimeters of water, that works out to be about 0.3 joules per liter. So in other words, normal tidal volume, normal pressure change, normal work of breathing. Notice that work of breathing is a mathematical term. So one of my pet peeves is when I hear somebody say the patient has an increased work of breathing. How do you know that? That means that it must be more than 0.7 joules per liter. So without making the measurements of volume and pressure and doing the math, you can't say there's an increased work of breathing. So better, again, this is my pet peeve, better to say the patient is generating a lot of effort to breathe, or the patient looks uncomfortable. Because work of breathing technically is a mathematical term. You've got to make measurements and do the math. The equation of motion says that the pressure generated by the respiratory muscles plus any pressure applied to the airway from a ventilator, for example, is equal to volume divided by compliance plus flow times resistance. So let's elaborate a little bit more on these things. So time constant we said is resistance times compliance. It so happens that it takes about 5 time constants, about 5 tau, to get gas into or out of an alveolus. The normal time constant we said is about 0.1 seconds, so normally it only takes about a half second to fill or empty your lungs. However, if you have a low compliance, it'll take less time to fill the lungs because the compliance will be decreased. So if the compliance is decreased, then the time constant will be decreased. And that's called a fast space. Or, if you have a high resistance, it'll take more time to fill or empty the lungs. So, higher resistance, longer time constant. Call that a slow space. So then gas distribution within the lungs is determined in part by regional differences in time constants. So parts of the lungs where there's a high resistance will fill slower. Parts of the lungs where there is a low compliance will fill faster. So work of breathing, we said, is determined by volume and pressure. Work of breathing is a number. It's a mathematical term. But the thing that I wanted to point out here is that the work of breathing is determined by the respiratory mechanics. So normally, normal breathing, you and me, the lowest work of breathing, shown by the blue line here, is at a respiratory rate of about 15 breaths per minute. So where do we usually breathe? At a respiratory rate of about 15 breaths per minute. Why do we breathe at 15 breaths per minute? That's the lowest work of breathing, normally. So we take a patient with decreased compliance. So this might be a patient with pulmonary fibrosis. With pulmonary fibrosis, now look at the total work of breathing. It is the lowest at a more rapid respiratory rate. So how do patients breathe with pulmonary fibrosis? They breathe 40 times a minute. And if you try to get that patient to breathe at 20 breaths per minute so that you can get them off of the ventilator, it's never going to happen. Why do they breathe fast? Because the work of breathing is the lowest. That's the easiest for them to breathe, breathing fast. Whereas patients with an increase in airways resistance, such as COPD, the total work of breathing is at a lower respiratory rate. So then it might make sense in a patient with COPD to try to encourage them to breathe slower, because that will decrease their work of breathing, and breathing slower will also make it easier to get respiratory time, and they'll have less air trapping. But we shouldn't try to make the patient with pulmonary fibrosis breathe like the patient with COPD. I mean, you can try, but it's not going to work, because the patient's brainstem is going to tell them otherwise. So the final point then is the equation of motion, which says that the pressure generated by the respiratory muscle plus airway pressure is equal to tidal volume divided by compliance plus flow times resistance. So let me look at some examples of how this might work during mechanical ventilation. So let's imagine that your patient's on volume-controlled ventilation. By definition, with volume-controlled ventilation, the volume and the flow are controlled by the ventilator. That's volume control by definition. So now if the patient is generating no inspiratory effort, the patient's paralyzed, the pressure that is required to deliver the breath will be determined by the size of the tidal volume, the compliance, the flow setting on the ventilator, and the resistance. So if you turn up the tidal volume, it'll take more pressure. Patient's lungs get stiffer, it takes more pressure. Patient develops bronchospasm or secretions in their airway, resistance goes up, airway pressure goes up. So this explains then the kinds of things that change airway pressure during volume control. Now let's say that during a volume control breath, the patient makes an increased effort. So the ventilator is controlling the volume and the flow, and now partway through the breath, the patient tries to take an effort. The only way this equation will balance is if the airway pressure goes down. So the ventilator is controlling flow, volume and flow. Compliance and resistance are determined by the patient's respiratory mechanics. So the patient breathes in during volume control, the airway pressure will go down. And that's what we see clinically when we look at the airway pressure waveform, and we see it develops that scooped out appearance as the patient is making an effort against the ventilator. Now, what about volume control ventilation, or pressure control ventilation? Same relationship. But now, by definition, we apply fixed pressure. That's what pressure control does. If the patient's generating no inspiratory effort, the volume and the flow, the tidal volume and the flow will be determined by respiratory mechanics. So, pressure control ventilation, fixed airway pressure, patient's lungs get stiffer, the tidal volume goes down. Has to. That's the only way the equation, that's the only way the math will work. Now what happens if the patient makes an inspiratory effort? Well, now if the patient makes an inspiratory effort, the volume and the flow have to increase. That's the only way the equation will balance. So what do you see clinically? Pressure control or pressure support. Patient breathes in harder, they get more flow and more volume. You sedate the patient, decrease their respiratory drive, their Respiratory muscle activity decreases, less flow, less volume. So this relationship always has to balance during mechanical ventilation. So when you go to the bedside and you assess your patient on the ventilator, this relationship, equation of motion, this math always applies. And the equation always has to balance. Now, what makes all of this very complicated in acutely ill patients, particularly mechanically ventilated patients in the ICU, is that there is a lot of heterogeneity within the lungs. So when we measure compliance and we measure resistance, we're assuming that all of the lung units are the same, but they're not. So imagine this patient who was up in the MICU about 15 years ago, and she has severe COPD due to LAM. So LAM is an abbreviation for a word that's about this long. You can look it up. I've never mastered how to pronounce it. So, a lot of people haven't. That's why I go just first do it. That's LAM. So it's a form of severe COPD that occurs in young women, and she had had a unilateral lung transplant about a year before this. So this is the native lung. See the really severe COPD and hyperinflation. This is the transplanted lung, which is now either infected or rejected. So here we have a lung that has a high resistance and a high compliance, like COPD. Here we have a lung that has a really normal resistance and a really low compliance. So now, when up here at the endotracheal tube, you're measuring plateau pressure and calculating resistance and compliance, doesn't really make any sense for this patient. Because what you get is you get an average of all of the lung. I can remember at rounds having a conversation with the team, and a very bright intern said, well, if we put in a double lumen endotracheal tube, couldn't we sort out, And the answer was, yes, but why? It's gonna be a lot more problem than the information that you're going to get from that. So then, gas flow into the lungs must overcome elastance and resistive forces. We talked about that. There's a pleural pressure gradient and regional time constants that affect gas distribution in the lungs. Airways are Starling resistance, and thus expiratory flow is largely effort independent. Flow limitation is what that's called. And compliance or resistance can be measured during mechanical ventilation.